Hello everyone, my name is Sinan. I'm from Turkey. First, I would like to thank the conference committee and moderators who provide me this opportunity. My topic is prevention cardiovascular events after percutaneous coronary intervention. There is no conflict of interest. Despite advances in medication, changes in treatment, and drop in risk factors such as smoking, hyperlipidemia, cardiovascular disease remain the leading cause of death in many European countries. PCI treatment doesn't cure the disease, but the patients have the opportunity to decrease certain risk factors by changing lifestyle. PCI is focal treatment of systemic problem. It's usually done only flow limiting lesions. All physiologically insignificant lesions are treated and to be taken care of medical management. Real success is achieved when the patient is followed up without any complications and puts impact in clinical outcome. What should the doctor pay attention to prevent recurrent events, to prevent death, improve symptoms, improve quality of life? K-life interventions includes cessation of smoking, optimal blood pressure control, diet advice, and weight control, encouraging physical activity, refer to cardiac rehabilitation, and of course, medical treatment, DAB treatment, and lipid-lowering therapy. Antiplatelet treatment. Antithrombotic treatment is mandatory in ACS patients. Millions of patients worldwide undergo coronary stenting each year for the treatment of ischemic heart disease. After PCI, dual antiplatelet therapy, consisting of aspirin and P2Y12 inhibitors is generally recommended. Ischemic and bleeding complications significantly influence the outcome of ACS patients and their overall mortality risk. Because of the reason, still the optimal duration of DAP is subject to debate. A longer duration of DAP is associated with lower thrombotic events but higher bleeding risk. We need to focus how which patients should be treated with short duration or standard duration or longer duration of DAP. But the real question is how to end these debates and how to provide really more tailored information so clinicians and patients can make better decisions together. In this area, the guidelines emphasize we should individualize care and we had the option treating people with either standard, short or longer duration DAP based on benefits and risk ratio. Like I said, there are a lot of randomized control trials, meta-analysis, short versus long, standard versus long treatments. In this slide, we see short-term versus standard therapy. We see short-term decreased primary bleeding outcome. Figure C and figure E, there is no differences between MACE and all-cause mortality between two groups. And subgroup analysis, ACS for primary bleeding outcome for MACE and for all-cause mortality at 1 year yielded similar results. And small choice trial, we see between two groups, there's no differences. And landmark analysis composite events in 3 months, there is no differences, and after that, yielded similar results. As to bleeding, we see P2Y12 inhibitor group decrease the bleeding rate, and landmark analysis of bleeding in 3 months, there is no differences, especially after 6 months, curve were diverging, the DAP group increased bleeding rate. Another trial, short versus standard or longer treatment. We see short treatment, short treatment in the landmark analysis of myocardial infarction at 6 months, there is no differences, but after 6 months, the curve were diverging and short duration DAP increased myocardial infarction rate, but there is no differences MACCE and all-cause death and type 2-5 bleeding. Long-term versus standard therapy. In this slide, we see long-term therapy decreased death, MI, stroke, but as expected, increased minor and major bleeding. Duration of dual antibody therapy, systemic review, network meta-analysis, long-term versus short-term, standard versus short-term. In this slide, we see long-term therapy decrease myocardial infarction and definite probable stent thrombosis, but increase MAIOR and any bleeding. Short-term versus long-term, there is no differences between the groups. And recently published non-STEMI AC's guideline, we see if the patient first evaluate bleeding risk, if the patient's low bleeding risk, guidelines recommend using 12 months dual antibody therapy. If the patient low bleeding risk and higher ischemic risk, extended therapy could be used. If the patient high or very high risk, 1 month, high risk 3 months, DAP therapy is recommended. After that, monotherapy is recommended. As to chronic coronary syndromes, DAP therapy is recommended for 6 months. If the patient higher bleeding risk, is recommended for 3 months. How do we risk stratify and decide who to treat, short or long? When we look at the slide, we see thrombosis and bleeding, the most favorite dreams of cardiologists. So bleeding increased with advanced age, stroke period bleeding, MA6, oral anticoagulation using and steroid therapy, anemia, and thrombosis risk increased with advanced age, ACS presentation, chronic kidney disease, diabetes mellitus, stent undersize, and complex PCI. Complex PCI includes 3 lesions treated, 3 stents implanted, and bifurcation lesions, main coronary lesions, including complex PCI. If you want to use risk score, you can use precise DAP score, and Paris Registry score. And we see after patients undergoing PCI, we see triple therapy first week in hospital, usually recommended. After that, if the patient's high bleeding risk, 6 months oral anticoagulation plus single antibiotic therapy, and after that, long-term using oral anticoagulation is recommended. If the patient's higher ischemic risk, first month triple therapy, after that to 12 months, oral anticoagulation plus single therapy is recommended. And lipid treatment. Low density lipoprotein cholesterol is well-established risk factor for cardiovascular disease, as evidenced by epidemiological and Mendelian randomization studies. Statins are effective in secondary prevention. Evidence from multiple randomized trials shows that statins reduce the risk of cardiovascular events in patients with history of cardiovascular disease. In this study, we see almost 25,000 patients admitted to the study, and we see half of the patient LDL-C levels less than 70 milligram per deciliters. So 70 milligram per deciliters was taken as references. We see greater than 70 and greater than 100 milligram per deciliters, myocardiovascular events, myocardial infarction, and coronary vascularization was increased. So we see 1 out every 2 patients had LDL-C measured after PCI. 1 out every 2 patients LDL-C less than 70 milligram per deciliters. LDL-C after coronary revascularization with PCI is strongly associated with subsequent incidence of MACE. By measuring LDL-C after PCI, patients who haven't reached LDL-C targets can be identified for further optimization. Lipid levels should be re-evaluated in 4 to 6 weeks after ACs to determine whether treatment goals have been achieved and to check for any safety issues. The guidelines recommend lipid levels should be re-evaluated in 4 to 6 weeks after ACs to determine whether reduction at least 50% from baseline goal levels of LDC less than 55 milligram per deciliter. If the LDC goal is not achieved after 4 to 6 weeks, a combination with ezetimibe is recommended. If the LVC goal is not achieved after forcing despite maximal tolerated statin and ezetimibe, adding PCSK9 inhibitor is recommended. And another health problem is smoking cessation. Smoking preventable risk factor for cardiovascular disease. Independent major risk factor for total atherosclerotic cardiovascular disease, coronary heart disease, cerebrovascular disease, and the risk of recurrent event is increased. In this slide, we see baseline smoking status appear to have no impact on death, MI, stroke, and MACCE. And look at the figure B, analyzing data for the smoking or not smoking. We see there is no differences between two groups. And however, using smoking status as time-dependent correlated follow-up, smoking was associated with an increased risk of death, MI, and stroke at final 5-year follow-up. After adjusting for confounding variables, current smoker, ex-smoker, and non-smoker, current smoker appeared to increase death and MI stroke, but appeared to no impact on MACCE. And if you look at the figure C, using smoking status as time-dependent correlated follow-up after adjusting baseline characteristic, non-smoking significantly lowered the risk of death, MI stroke, and MACCE. Smoking is associated with adverse clinical outcomes, especially MI after revascularization for complex CAD. And blood pressure control. Lowering blood pressure reduces the risk of cardiovascular events and death. Randomized trials fail to demonstrate the benefit of targets less than 140 for 90 millimeter Hg. Large meta-analysis trials, intensive blood pressure lowering was associated with decreased cardiovascular events. A circular trial showed that systolic blood pressure between 120 to 129 as taken references, systolic blood pressure less than 120 and greater than systolic blood pressure 140 is increased death, myocardial infarction, and stroke. All cause that have diastolic blood pressure, diastolic blood pressure 70 to 79 as taken references, diastolic blood pressure less than 70 and greater than 80 increase death, myocardial infarction, and stroke. And cardiovascular death and myocardial infarction yield similar results. Look at the J curve. We see systolic blood pressure and our average diastolic blood pressure. Systolic blood pressure less than 120 or greater than 130 is increased hazard ratio. And the guidelines recommended target systolic blood pressure to less than 130 mmHg if tolerated, but not less than 120 mmHg. And target diastolic blood pressure to less than 80 mmHg, but not less than 70 mmHg. And cardiac rehabilitation, CCS 90-2000, non-STEMI 2020, 2017 STEMI guidelines recommend the cardiac rehabilitation class per level A. Cardiac rehabilitation, valuable part of the treatment on CAD, is secondary prevention by having beneficial effect on the risk factors and by substantially decreasing mortality. Cardiac rehabilitation includes medical evaluation, physical activity, lifestyle education, and support. Cardiac rehabilitation leads to gain strength, cut bad habits such as smoking, manage your weight, find ways to manage stress, Learn how to cope with heart disease, decrease your risk of coronary disease and other heart conditions. In this graphic, we see after cardiac surgery and after percutaneous surgery. After cardiac surgery, the patients referred to cardiovascular centers much more than after PCI. Take-home message: a further immunization of depth duration based on ischemic and bleeding risk. Target blood pressure between 120 to 130 mmHg and diastolic blood pressure between 7 to 80 mmHg. Use high-dose statin therapy and evaluate in for 4 to 6 weeks. Advise stop smoking and refer to cardiac rehabilitation. Thank you for your attention.